Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of hyponatraemia. Dr. Travis Brown, I like to research what we talk about, but I haven't had a chance because I'm not even sure how to spell hyponatraemia.
This is one of those areas where we like to inundate people with big long terms so they don't know what it's talking about. And if we break down the term hypo, low, natremia, so natra refers to sodium, emia is blood, so low sodium blood.
Is that low salt in the blood?
That's right. And so this story actually starts us in early 1900s, and this is because it took us a while to understand what was actually going on with salt in the blood. And this takes us back to the Liverpool cholera riots in 1832, and this was a pandemic of cholera. Now, it's believed to have started in Bengal in 1823, actually, in Bangladesh. And this is what they would have said would have been a slow-moving pandemic. And the reason it's a slow-moving is because transportation was slow at those times. So a pandemic or an epidemic could only move at the pace of a person.
Of humans.
Yeah, that's right. So walking along, so if you were unwell, you couldn't walk anywhere. Well, we were starting to get railways and we were starting to get shipping at this time, extensive movement of populations. And so it sort of travelled its way across into Europe. And this was the beginning of the industrial age. And so it's believed to then have hit England late 1820s, early 1830s. And this is when it spread to England and Newcastle, Edinburgh and Liverpool. Now, the leading theory of the time was miasma, which we've spoken about this. It somehow spreads through bad air. And so when you've got air passing it on, it was either these vapours that were spread out, or the other alternative was this was just God punishing the population for being bad, evil and sinning.
Didn't we think COVID was transferred by miasma because you breathe out and the germs are in the air?
When you think about it, it's not actually a bad theory because respiratory illnesses are actually miasmas. But this one wasn't. This was a diarrhea type, this is cholera. So this is Vibrio cholera. And Vibrio cholera is a bacteria that's passed. It's the fecal oral route. So we try not to think about that too much when you're unwell. But you can get large numbers of the Vibrio cholera that pretty much it's able to survive through the stomach, and then it adheres to the intestinal lining, and that's where it just causes, there's lots of toxins that it can produce. It adheres to the gastrointestinal tract, and effectively it just develops this really profuse watery diarrhea. And you can lose up to 1 litre an hour of water from this disease.
That does not sound good.
And that's the problem, is that it's so profuse that people can often die within a day.
Yeah, exactly.
And so you can have, what ends up happening is you lose so much volume, you go into hypovolemic shock, so low volume in your blood, you lose too much fluid and die. And so this was also the 19th century. This is the perfect, cities are the actual perfect incubator for cholera at this time. So they had sewage and night soil, and this was just tipped into streets. This was into lanes. There was no drains, so the sewage just either sat there or was stagnant or went into the rivers, which was also your drinking source. You had ditches, lakes, rivers, which was also, spillage would go into these areas.
It changes when you look at the postcard from those times. Oh, it doesn't capture the smell.
No, it doesn't. And this was not far from the great stink of London as well, where it just became overbearing even for the parliamentarians, which must be something in 19th centuries. But this was essentially just a cycle of illness and spread. And cholera is just running rampant through the area. They estimate about 22,000 people died from this. It had a mortality rate of 70%. And so this is just a phenomenal kind of illness going through. The problem for the aristocracy at the time was it wasn't limited just to the poor. This was an illness that could hit the affluent, the powerful. And so it wasn't just confined to what they call basement dwellers or the poor or the destitute.
Podcasters.
And this was, rich and powerful was susceptible. And the problem was 19th century medicine was not ready to treat this. They didn't know what happened. They didn't know how it was caused. And so they had 24 different treatments for cholera, all of them ineffective. But let's go through a few of them. So they had brandy and opium.
Yep, that'll do. It's worth trying.
And so they said it was ineffective but possibly soothing for the patient. They had bleeding. So you would get blood loss. So if you were bleeding profusely, well, you would get bleeding done for you, so phlebotomy. Even if you were having lots of diarrhea and vomiting, they thought, well, let's take some blood off. There's clearly a blockage somewhere. But usually that would worsen the condition because you're already dehydrated and you'll lose more volume. They would often give mercury chloride, which was a purging agent. So if you're vomiting and diarrhea, they would give you something to make you do vomiting and diarrhea more. Again, this would make you worse.
I don't understand the logic.
Well, I don't either. There was also cautery. So you would have hot irons and caustic agents that would be applied to you and would burn, and the burn would then theoretically draw out the illness from you, and so you would reduce the illness in the patient.
Some people just call that Friday night.
And so then you would also have suffocating under a feather bed, and so you would actually put the patient a feather bed on top of the patient.
Hang on, are you making this up?
No, I'm not. And this was a theory of you would sweat out the disease. So they would either wrap you up or put a large feather bed on top of you and theoretically sweat out the illness and disease.
Was that Dr. John Denver?
So it was just, again, the one there's one that you might like the most. This was bastionating the feet. And so you would slap and beat the bottom of the soles of someone's feet to increase the blood flow to the feet area, and this would stimulate your circulation.
That's all right.
So of all that one, you would have gone bastionating the feet?
I would have started with cocaine and the...
opium.
Opium. And that would have been my second.
I think cocaine was probably your own, but probably that would have worked just as well as anything else I imagine they had. So, look, the problem with this is cholera, a lot of people died. And a lot of people were going to hospital, but even if they went to hospital, you're getting that treatment. There's nothing that's going to help. And the problem with this was it had just happened a few years before. The William Burke and William Hare, I'm not sure if that is named will ring a bell, but these people were executed for stealing and murdering people to provide bodies to the medical schools. And so what happened at this time was there was a doctor, Dr. William Rathbone, who was a respected doctor in Liverpool. He paid two men just before this time to actually go to the local cemetery and dig up bodies. And this was because they didn't have enough bodies to dissect. And what Mr. Rathbone was doing was he was paying them to get bodies. And they got caught. And they went to court where they were convicted, but they were just given a fine, which Dr. Rathbone then paid for them. So the populace was actually really upset because effectively nothing happened. They got a fine and they were paid for. The problem was Dr. Rathbone at this time then changed the law. He was instrumental changing the law that unclaimed bodies were able to be used and volunteered or given to medical institutes for dissection so that they could learn. Now, these bodies were in workhouses, in prisons, in hospitals, and so these bodies could be claimed for dissection. And the problem with that is that the population then thought a whole bunch of people are dying and they're going and being claimed by doctors. So they're thinking the doctors are actually killing these people with cholera to be able to dissect them later. And the problem with that is
And that was before Truth Social was created.
And the problem is that in the same year, they found at Liverpool, the Liverpool docks, a whole bunch of bodies with crates with very suspicious smells being sent to Edinburgh. And the police were called, they opened it up, and they found 19 half-salted bodies going to be sent to Edinburgh for dissection and usage. The police then sort of followed this up and found a whole industry that had been parked next to a cemetery where they dug bodies up and then would transport them around. And so this cholera epidemic, the population's thinking, actually, this is just a ruse to get more dead bodies. And so doctors, when they were admitting patients, were actually being called burkers and murderers at this time, which, again, caused problems, people dying. And so it's this weird kind of environment. But the problem at this time, with cholera going everywhere, is doctors were genuinely trying to work out what's actually happening with these patients. They still didn't know about Vibrio cholera. They didn't know it was a bacterial disease. But there is one doctor, he's by the name of William O'Shannessy, and he started investigating the bodies of patients who had died and looked at the patient's blood and found that they had lost a huge amount of fluid from cholera. And looking at blood, he estimated about 4/5 of the fluid portion of water and salts had been reduced. So if you had about 1,000 parts of blood, they would have lost up to about 860 parts of water and salts. And that's just a huge amount of volume to lose. And so there was another doctor, Dr. Thomas Larter, who read this and said, well, okay, what if we replace the fluid part? What happens when we do that? And so did some experiments. Now, this was experiments on patients, but what they looked at was how do we replace the salty part of this water? And he started doing an experiment.
So soon as I learnt the result of Dr. O'Shannessy's analysis, I attempted to restore the blood to its natural state by injecting copiously into the larger intestines warm water, holding in solution the requisite salts, and also administered quantities from time to time by the mouth, trusting that the power of absorption might not be altogether lost, but by these means I produced in no case any permanent benefit. But, on the contrary, I thought the torming, vomiting and purging were much aggravated thereby, to the further reduction of the little remaining strength of the patient, finding thus that such, in common with all the ordinary means in use, was either useful or hurtful, I at length resolved to throw the fluid immediately into the circulation. In this, having no precedent to direct me, I proceeded with much caution. The first subject of experiment was an aged female on whom all the usual remedies had been fully tried without producing one good symptom, the disease, uninterrupted, holding steadily on its course. She had apparently reached the last moments of her earthly existence, and now nothing could injure her. Indeed, so entirely was she reduced that I feared I should be unable to get my apparatus ready ere she expired. Having inserted a tube into the basilic vein, cautiously, anxiously, I watched the effects. Ounce after ounce was injected, but no visible change was produced. Still persevering, I thought she began to breathe less laboriously. Soon the sharpened features and sunken eye and fallen jaw, pale and cold, bearing the manifest impress of death's signet, began to glow with returning animation. The pulse, which had long ceased, returned to the wrist. At first small and quick, but by degrees it became more and more distinct, fuller, slower and firmer. And in the short space of half an hour, when 6 pints had been injected, she expressed in firm voice that she was free from all uneasiness, actually became jocular, and fancied all she needed was a little sleep. Her extremities were warm, and every feature bore the aspect of comfort and health.
And so this is fluid resuscitation, and this is fluid that goes into the patient's veins, and this is salty water. This isn't just any water. If you just put straight water into your veins, you would kill the cells. They would just lyse. If you put too salty water in it, then that will dehydrate more, so there's problems. So this is the first case of someone doing fluid resuscitation, which would have saved her life. And this is, now, unfortunately, this lesson was lost for about 70 years. And so this is something that came back around and we understood more about it at that time. But you start to see our understanding of physiology, of dehydration, of fluid, and you're starting to see salt in water. And this is something we measure. This is why hyponatremia is important. You're actually changing the chemical constituents of the blood. And so if it gets too low, that's bad. If it gets too high, that's bad. And so keeping that concentration is important. And it's actually a really common problem in patients because we have medications that will affect the salt balance. And so this is why it's important. The discussion today is focusing more on community-based patients. So this is where we start to see the little bit of a separation. You have patients in hospital that will have hyponatremia. You have a lab down the hall or on a different floor. And so that result is a little bit different to when patients walk into the community to a collection centre and have a blood test and then it gets transported. There are two different kind of communities that you're dealing with and different problems. And again, the patient walking around with the same value of a hyponatremia will be potentially different to someone with the same value that's sitting in a hospital. And so we're going to focus on community-based patients because that's who our listeners are, our community-based doctors, and we're going to try and see if we can help manage this challenging area of hyponatremia.
Now, let me bang the bottom of your feet. Dr. Michael Page is a chemical pathologist and Chief Executive Officer at Clinipath in Western Australia. Michael is a senior lecturer at the UWA Medical School and an examiner for the Royal College of Pathologists of Australasia. He's also the president of the Australian Medical Association WA. Michael's a returning guest on This Medical Life podcast. Michael, welcome back.
Good to be with you, Travis. Good to be with you, Stephen.
What's the most common cause of hyponatremia for patients in the community?
Well, look, I think there's a natural tendency when we think about hyponatremia to immediately think about SIADH or syndrome of inappropriate antidiuretic hormone secretion, although it's really the last thing you think about in some ways because it's a diagnosis of exclusion. But it is a very common cause of hyponatremia. It's the most common cause of hyponatremia in the hospital setting, and it's a very common cause in the community setting, although perhaps not the most common. In the community, we see a lot of hyponatremia due to diuretic use, in particular thiazide diuretics, and really that is the number one thing to firstly exclude in any community-based patient with hyponatremia, because doing any additional blood or urine testing to establish any alternative or additional cause for hyponatremia on top of diuretic use is pretty futile because those results will all be affected by the effects of diuretics on renal sodium and water handling, making the results impossible to interpret in most instances.
Michael, just before we started, I jokingly referred to Dr. Google. Is there any danger of over-the-counter diuretics of people who have gone off on their own volition who might be overdosing that could be in that cluster of causes?
I mean, it's a very good question, Stephen. I suppose there are some herbal medicines that are supposed or reputed to have diuretic effects, so-called natural diuretics. Are they a significant cause of hyponatremia? Look, I think it's something to be aware of, and always when GPs find something unexpected in their patients, that is routinely one of the questions I'll ask them about any over-the-counter or herbal medicines they might be taking, because there's often unexpected surprises there.
When you're looking at a patient with hyponatremia, is there any other results you'd like to check when assessing?
The osmolalities and the urine testing are important. I mean, before you go down that rabbit hole of requesting additional tests that then you have to figure out how to interpret. It is important to exclude a few common causes as a starting point. So there are endocrine causes of hyponatremia, thyroid disease. So you exclude that by checking a serum TSH, thyroid stimulating hormone. You always want to exclude adrenal insufficiency by checking serum cortisol, ideally in the early morning if possible. And of course, ask if the patient's on a diuretic. The next thing to do, once you've excluded those, I suppose, mimics or traps, is to exclude pseudohyponatremia. And so the way to do that is to check the serum osmolality, so measure the serum osmolality and determine if there is a significant gap between the measured serum osmolality and the predicted or calculated osmolality, which you can determine by, usually there's a few different formulae around, but usually doubling the sodium concentration, adding the urea and the glucose concentrations to that. And if you see a gap between the measured and the calculated serum osmolality of more than maybe about 10 milliosmoles per litre, then you could be dealing with pseudohyponatremia. And so from there, you then go on and measure the urine osmolality, measure the urine sodium, and those are really the key additional tests in the initial diagnosis of hyponatremia.
There is the academic ones when you read the books where they talk about like severe hyperlipidemia and monoclonal paraprotein. In practice, do you see that much that's actually a big cause?
You do actually, Travis. The main ones, as you said, the main causes of pseudohyponatremia are severe hyperlipidemia, which is usually hypertriglyceridemia, although you can see it with very, very high cholesterol in some cases. And of course, as you say, a monoclonal paraprotein, as we might see in something like myeloma. So you'd usually see that at very high paraprotein concentration. So someone with MGUS, monoclonal gammopathy of uncertain significance, with a relatively low paraprotein concentration, it'd be unusual to see significant pseudohyponatremia. But we do, we've got an epidemic of diabetes, as you know, diabetic dyslipidemia, high alcohol intake, high fat diet causes high triglycerides. A lot of people have significant hypertriglyceridemia, and so we do occasionally see pseudohyponatremia in that setting. It's usually not severe in the sense that the sodium will usually only be slightly decreased, but nonetheless it will trigger a whole lot of other investigations if we see unexpected hyponatremia, so it is important to exclude.
Do you have a trick for people that we talk about, like psychosomatic, so people drinking excessive amount of waters that causes themselves hyponatremia? Is there any kind of way to test for that?
Yeah, I mean, these patients will usually present, so they might present with hyponatremia as the presenting, not the presenting problem. They don't usually walk in and say, I feel a bit hyponatremic, but it might be the finding that triggers additional investigation. But they might come in with what's referred to as the polyuria polydipsia syndrome. In other words, they are thirsty all the time, they're drinking all the time, and they're passing large volumes of water. Now, that could be because of some actual illness like or a physical illness like diabetes, uncontrolled diabetes, which might be undiagnosed, in which case, there's polyuria, so passing large volumes of urine, and then that's making them thirsty because their volume deplete all the time. But then there is this thing called primary, or sometimes called psychogenic polydipsia, where people are just drinking a lot of water habitually, and that will make them hyponatremic. Look, I guess if someone presents with polyuria polydipsia syndrome, in other words, they're coming in and that's their primary complaint, you need to exclude diabetes insipidus. And diabetes insipidus is completely different entity from diabetes mellitus, and it's due to either your pituitary gland not making enough antidiuretic hormone, or the kidneys are not sensitive to the effects of antidiuretic hormone, so-called central or nephrogenic, respectively, diabetes insipidus. Of course, if the patient's hyponatremic, then you can basically exclude DI. So in other words, if the patient comes in, they're complaining of polyuria, polydipsia, and they're found to be hyponatremic, it's not going to be diabetes insipidus. In diabetes insipidus, the sodium will usually be high normal or high. So then to exclude that primary polydipsia in someone with hyponatremia, and they will sometimes deny that they're drinking lots of water, even if they might be. So measuring the urine osmolality is the starting point there. You expect it to be low. In SIADH, the urine osmolality will be higher. If it's very low in someone with hyponatremia, it's more likely to be so-called primary polydipsia, where they're just drinking too much water. That expanded plasma volume caused by that fluid is going to suppress ADH. It should suppress ADH, enabling the diuresis of free water and diluting the urine, which gives it its low osmolality.
Now, one of the tricks that I got from David Deem, who is a chemical pathologist, he was saying that if a GP is worried about them just having excessive amount of water, at night, what you do is you get the patient to completely fast, not have any water overnight, and then do a urine spot in the morning. And if it's concentrated, then it means their kidneys are working appropriately, and it gives you an idea of it potentially could be an intake amount. Found that as a really useful test to try and say, is this not behavioural, but is this being exacerbated by a patient having excessive amounts? So I found that really useful. But when we're looking at a scenario, so let's say a patient is in the community, an elderly patient, and has a mild hyponatremia, so about 131 millimole per litre. What is your approach for that general practitioner?
Yeah, so this is a very common scenario. An older person in the community, they might be on several medications, potentially including diuretics, potentially including other medications that can cause SIADH, like some antidepressants, for instance. They might have cardiovascular or kidney disease, which can affect their fluid balance and the way their kidneys handle water and sodium. And usually this would be an asymptomatic presentation with quite mild hyponatremia, which in some instances might not be of any major significance. But generally, it is just to go back to that approach of excluding any medications that might be causing or contributing to the hyponatremia. If they're not, assessing the volume status to see if they're undervolume, euvolemic, or hypervolemic, and then following the kind of protocol for workup of hyponatremia, exclude adrenal disease, exclude thyroid disease, and then check the urine osmolality and see where to go from there. If the urine osmolality is relatively high, then you might be looking at SIADH. If it's low, it could be primary polydipsia or something else. But again, it will just depend on the clinical circumstances.
The result changes to 128 millimole per litre. Does your approach change at all?
Yeah, look, I mean, with lower sodium, you would tend to worry a bit more. I mean, the investigation is not going to change in terms of what investigative protocol you use. The urgency of investigating and then attempting to treat the underlying cause will be different, but it will also depend on how quickly you think it's come on. If it's come on very quickly, the patient's going to be more susceptible to the effects of hyponatremia, so seizures and neuropsychiatric effects from hyponatremia are much more likely if it's of rapid onset. If it's been developing for years, a sodium of 128 millimoles per litre, is probably not going to produce any symptoms, whereas if it's happened quite quickly, potentially it might. Or and the other thing is it might indicate there's some underlying condition that might make it continue to drop down into dangerous levels. And that same principle applies to a lot of electrolyte abnormalities. A patient with chronic kidney disease can wander around with a potassium of 6.2 and it not cause any problems, whereas in anyone else, a sudden increase of your potassium from 4 to 6 might give you some trouble. So there is that process of adaptation to a lot of these electrolyte abnormalities.
What level do you tend to say is either red flag level or potentially considering referring a patient to hospital?
Yeah, look, I think if you've got, if I was doing a chemical pathology on call and I got an after hours call from a from the lab with a very low sodium in someone out of the blue, unexpected, and it's less than 120, I would probably be calling that patient and telling them to advising them to go to hospital for investigation. If there was no clear cause, if they were symptomatic, then absolutely every time they need to go to hospital. If they're asymptomatic, it will depend a little bit on the clinical circumstances. If it's over 120, 125, it can probably wait till the next day. But we're in a bit of an evidence-free zone when we're trying to pick numbers that are associated with risk of people coming to harm within the next 12 or 24 hours. But generally speaking, if it's under 120, that's getting pretty serious.
On that note, let's pause for a moment because I just need to top up my glass of water, and we will resume this conversation momentarily. We continue now our discussion with Dr. Michael Page. There are some commonly asked questions and conditions associated with hyponatremia. So what tests do you like to do to assess it?
After you exclude diuretic use as a cause of hyponatremia, the first line test would be TSH to exclude thyroid disease, morning cortisol to exclude adrenal insufficiency, plasma glucose, and plasma osmolality with urine osmolality and urine sodium, which will just help you narrow down the cause in the first instance. You also want to know what the serum creatinine is so you can get an estimate of renal function. You'll also need to know the serum urea so that you can calculate the expected osmolality and compare it with the measured osmolality to see if there's a gap there, which might give you a clue to pseudohyponatremia.
How useful do you find urine and serum sodium and osmolality?
Look, I'm not sure if I'd ever want to be choosing between my favourite children, but in this case, I would probably say osmolality is the higher yield of the two tests, but they're both important. They'll usually be concordant, so the osmolality, if it's high, usually will be associated with a higher sodium and vice versa, but there are some instances where they're not. Both are useful. They tell you slightly different things. Urine sodium can be useful as a surrogate for intravascular volume status because clinical examination is not always reliable to assess someone's intravascular volume, but there are other factors that can affect urine sodium as well. So urine osmolality is really an absolutely key test in pretty much every case of hyponatremia if it's not diuretic induced.
Now, we always get this question a lot, SIADH. What is it and when is it relevant?
Yeah, so it stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. It implies that something's gone wrong at the level of the posterior pituitary gland where ADH, which is otherwise called vasopressin, is produced, and it's making too much of it. It's churning out ADH. That's preventing the excretion of free water at the level of the kidneys, and that relatively dilutes the plasma because you're holding on to more water. That lowers the plasma sodium concentration, but the patient usually remains euvolemic. So it can be confusing because people think, well, if you're making too much antidiuretic hormone, shouldn't you be hypervolemic? But we always think of SIADH as being a euvolemic condition, but the reason is because that extra fluid volume will suppress the renin-angiotensin-aldosterone system, so that keeps the volume down through the excretion of sodium, and that further excretion of sodium accompanied by water further exacerbates the hyponatremia. So you see it a lot in patients who have, a lot of the time it's in hospital, it's patients who are on certain medication, it's patients who've had recent surgery, major trauma, sepsis, for example. There's always this argument about whether SIADH is the right name for the condition. So, for instance, if someone's had major surgery, the relative increase in ADH secretion is physiological and adaptive, and therefore is it inappropriate? So the more nerdy types like to get into those sorts of pedantic arguments over nomenclature and whether it's truly inappropriate.
How do you test for SIADH?
Yeah, so again, you'd assess the patient's volume status, which you'd expect to be euvolemic, exclude the other causes of hyponatremia, diuretic use, hypoglycemia, exclude pseudohyponatremia, and then you look at the urine osmolality, and that's the key investigation is the urine osmolality. Generally, it's going to be more than 100 milliosmoles per kilogram in SIADH. If it's lower than that, it implies significant free water excretion, which means ADH is really switched off, appropriately for the low sodium and likely low volume. So And there'll sometimes be a known cause in the history, like there might be, for instance, recent surgery, severe illness, or medications like SSRIs, selective serotonin reuptake inhibitors used for depression and anxiety, and occasionally a neuroendocrine tumour. So there are these neuroendocrine lung tumours, for instance, that make ADH, and so occasionally one of those will appear.
Do you recommend or have any algorithms or guidelines for assessing hyponatremia?
There's a lot of different algorithms out there. I mean, they're typically, you'd hope they'd be quite similar to one another. Occasionally, they differ a little bit in what emphasis they put on, for instance, urine sodium, or what emphasis they put on clinical assessment of volume status. It is difficult. Hyponatremia is a very difficult topic to learn. There's no doubt. In the clinical world, often there'll be more than one cause of hyponatremia, or it won't be clear what the predominant cause is. So it is a very difficult topic to learn. The concepts are hard, and it doesn't make it any easier that the algorithms and flowcharts that you look at are sometimes a little bit different. So generally speaking, I would say it's a bit of a non-answer to your question, but I would just find one that makes sense to you, that you can understand and remember, and go from there. So, there's plenty out there in standard textbooks, up to date and elsewhere.
Well, just in closing, are there any final thoughts or advice you have for doctors on hyponatremia? One
of the really useful things that I remember learning as a medical student, it was almost a throwaway line from a physician in a multidisciplinary meeting, but I still remember it, was that hyponatremia is frequently a primary problem of water rather than sodium. So as a starting point, yes, the name hyponatremia implies a low sodium concentration in the water fraction of blood, but often that's because there's too much water as opposed to not enough sodium in the body. So that's a useful way to think about it conceptually, and it helps you to just get away from thinking just about where the sodium has gone or whether there's not enough sodium coming into the system. Actually, you've got to think about water balance, and this is a disorder of water balance as opposed to sodium in many instances.
Wow. Well, thank you so much. It's been fascinating. Just me being the non-doctor, just the levels of complexity around this and the different pathways. Fascinating as always. Dr. Michael Page, thank you for being part of This Medical Life.
My pleasure.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/The Real Steve Davis. This has been a Pathnotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.